thank you, Todd and Elliot, and all the organizers for this conference. It's really terrific to be here and be a part of this. I really appreciate the invitation. My marching orders were to get to current evidence-based guidelines for VTE prophylaxis. You know, you don't see it up there, but my Twitter page has these slides. So if you're interested in these slides and you don't like taking pictures of those slides, you can download from a link these slides. So way back in time, we're going to have to get to the current guidelines, but way back in time, we had Virchow, who was discussing thrombi occurring in the veins, particularly in the extremities. He wrote up this paper about the migration to PE. Is it possible that the bottom part of that slide is cut off? It'd be great if we can get the bottom part or maybe minimize that. In any case, the Virchow's Triad came out in the 1950s, stasis of blood flow, endothelial injury, and hypercoagulability. This is our PIM question for medical students, but Virchow actually didn't have this anywhere in his paper. If you asked him about Virchow's Triad, he would look at you confused because he didn't invent the term and because he spoke German. So next up, it brings us to our, next slide, please, our Virchow of the modern era. Dr. Gertz, and I have to say, I frequently deal with high A-list celebrities in Beverly Hills, and I'm not impressed much, but having Dr. Gertz here is just terrific, and I really appreciate your history in this subject. And even in talking about guidelines, we have to talk about two papers that you touched on. The first was the high rate of VTE presence in trauma patients. And the second was this comparison of heparin to enoxaparin, showing the superiority of enoxaparin. And this really founded our guidelines today. Next slide. And it's the methodology for this second paper is probably more important now than the findings because it was double-blind, randomized controlled trial, well conducted, but the first dose of VT prophylaxis was given within 36 hours. So we struggle with this today. For procedures, in most cases, there was no interruption in therapy unless it was something major like spinal fixation when a single preoperative dose was held. And we struggle with this today because in reality with spine surgery, sometimes I have to hold days of prophylaxis. For TBI patients, so severe TBI, those with major bleeds were held, but those with cerebral contusions, DAI, localized petechial hemorrhage, it was continued. And we struggle with TBI today with our guidelines. Next slide. So we're trying to get to the current guidelines, and we saw a nice summary of previous guidelines, but I think the CHEST guidelines from 2012 were really the guidelines among all guidelines, and they're still quoted today. These 2012 guidelines talked about how to treat VTE disease, how to deal with HIT, perioperative management of antithrombotic therapy, the new drugs in 2012, the diagnosis of DVT, the prevention of VTE in orthopedic surgery patients, but this was largely a paper based on elective surgery. This wasn't really for trauma patients. So what did we do for trauma patients? Next slide. So for the 2012 CHEST guidelines, trauma patients were lumped in one paper. We needed a little bit more. We need a little bit more here with this. The reality is, it was just a subset of this paper. We should have had in one paper an entire summary for trauma, but unfortunately, it was within these guidelines, and they're still quoted today. Next slide. And what was the expert guidance from these? Well, the first was, and mind you, this is after Dr. Gertz's paper from '96, that major trauma patients could have unfractionated heparin, enoxaparin, or leg squeezers. Any of those three were preferable over no prophylaxis. For major trauma patients with spinal cord injury or TBI, the suggestion was to combine either heparin or enoxaparin with leg squeezers. So it was really two steps forward, one step back. This was something a lot of people still believe in today, and it's frequently quoted, and it's something we have to deal with in our trauma centers. Next slide. So to get to the current guidelines, we have to realize there's a history here, the 1996 guidelines, the 2012, and then today. And I think that although there's a number of guidelines that have led to this point, we're all sort of bricks in a wall. I really think the Western trauma guidelines and the AAST-COT are really the two to go to for evidence-based guidelines for trauma patients. I did have some hand in both of these, so if I'm overly critical, I'm probably criticizing what I did for these. But let's talk about what they do. And next slide. I figured I would do it in a compare and contrast method, that sometimes it's better to learn things if you can see what's a little bit different with them. And this entire conference is going to be dealt with a more in-depth look at the literature. So I'm sort of cutting to the head on the line for some of your projects, so you can discuss where I was right or wrong in my summary based on these guidelines. Next slide. So we'll say here, enoxaparin is superior to heparin. Come on, really? There are a small but vocal minority of trauma centers that still believe heparin is non-inferior to enoxaparin. Both sets of evidence-based guidelines, curiously enough, recommend heparin sub-Q for patients with a low creatinine clearance. There is a slight difference between the guidelines that for the AAST-COT, there's a recommendation to bump up that heparin dose to 7,500 Q8 rather than the typical dose of 5,000. But nearly all patients are going to be based on the guidance here that enoxaparin should be given. I'm very interested in going forward with the idea that we can dose enoxaparin in patients with low creatinine clearance or in renal failure, but I can tell you that my pharmacist would balk at that, and right now we need to do that under a very strict trial like we've done some of these. Next slide. So this was touched on, but I just want to use this as an opportunity to quote a paper from Workington in the mid-90s that looked at the rate of HIT and enoxaparin. I see some hand waving here that there's a low rate of HIT with enoxaparin, but this was a double-blind randomized controlled trial. Next slide. And it really just showed that the rate of HIT is 0%. Next slide. So I think that what happens is that with HIT, if a patient is on enoxaparin and there's a development of HIT, that patient probably had a heparin flush or was on CRT or was in IR and got a little heparin down there. The rate of HIT in enoxaparin is 0%, and I absolutely just adore hearing that here, that there's just, you do away with HIT if you only use enoxaparin. And that, almost among every other argument, is a reason to switch to enoxaparin. And I think that when you hear the centers that say, well, we use heparin, it's not equivalent, enoxaparin is more expensive, we don't follow weight or anti-10A levels, you have to go back to this paper that you're going to do away with HIT at prophylactic doses of enoxaparin, you have a 0 rate of HIT. Next slide. So the evidence to support using enoxaparin at 30 or 40, so 30 twice a day or 40 once a day, has also been looked at. So the argument for people who like heparin is this 5,000 TID is different from Dr. Gertz's studies, that it's superior, but that's actually been refuted in a number of papers, including this one, that for VTE, PE, DVT, various incarnations, enoxaparin is superior than heparin 5,000 units TID. So the literature really is there. Next slide. What we do have to look at is the literature that supports the other side. There's a nicely designed randomized controlled trial out of San Diego that looked at the rate of VTE when you had heparin TID, or heparin Q8 versus enoxaparin 30 Q12. And the VTE rate was 8.2% versus the enoxaparin VTE rate of 5.1. And this was considered non-inferior because the p-value was 0.2. The one challenge for this paper is that the power analysis was designed based on Dr. Gertz's screening using scintigraphy for all patients, and this paper used selective screening. So at design, the power analysis didn't allot enough patients to this study. I think they would have gotten significance about the superiority of enoxaparin. But moving forward to this next paper, this is more recent. So two centers, one uses enoxaparin more, the other one uses heparin 5,000 more. And there was non-inferiority of heparin Q8. I think there's a number of challenges. We see a large percentage of TBI and even other patients who were started on heparin and transitions to enoxaparin. I don't think that was addressed in this paper. Missed doses were not addressed. But I think we have to look at the other side and say, well, why could heparin be non-inferior? And I think we see it, and I can show in some later studies, that people feel more comfortable with heparin. They'll start it earlier. They will hold it less frequently, and we have to continue to push that. We've made inroads, but some surgeons in my hospital will start a pelvic fracture on heparin and let us transition to enoxaparin. With TBI, it's very common to do this. I would say that these comparisons use an outdated dose of enoxaparin, that we've moved on with this dosing, and again, this HIT idea, it's being ignored, and I think it needs to be brought up based on that first paper by Workington. So it's time to surrender the heparin unfractionated for prophylaxis. Next slide. So after a very long time, we're moving from 30 Q12 to 40 or more Q12. There's some similarities in these guidelines. The Western trauma says start all patients on 40, start most patients on 40 Q12 except for some limitations, which I'll discuss. And then the AAST COT actually has this weight-based dosing. So start most patients on 40, but also consider weight-based dosing at that immediate dose, where Western trauma says do that weight-based dosing a little bit later. So next slide. So why is that? We see repeatedly when we use anti-10A levels to guide the therapy that the median dose for most trauma patients, the median dose for all trauma patients is 40, so most patients can be started on 40, and a high percentage of these patients require more than 40, so that you really have to titrate your dosing higher for most patients, whether they're burns, orthopedic, or general trauma patients, which is from each of these slides here. Next slide. So who do you put on 30? Well, there's safety here. And both of these expert guidelines agree on this, that low normal creatinine clearance, age greater than 65, TBI, spinal cord injury, or pregnancy should be started on 30 Q12. But I would say that we're evolving from this. We're seeing that for patients with a low weight, they certainly require higher doses. We saw at Western trauma that patients 65 and older might require higher doses. TBI and spinal cord injury at our hospital, we've shown the median dose for both of these is actually 40. So if you start them on 40, you're going to get to that goal threshold. I know that the guidelines use the obstetrics guidelines as a reference to how to dose in pregnancy, and those are 30 Q12, but I'm starting to see in the gyn-onc guidelines this 40 Q12 plus anti-10A levels. So different societies are getting on board with the higher dosing. Next slide. So weight-based dosing, and I think this deserves a little more discussion because I heard from Dr. Geertz how they do it. So Western trauma says start on 40 and then do weight-based dosing and guide by anti-10A levels. AAST COT says from the start consider weight-based dosing, but then titrate by anti-10A levels. And I think that last point, titrating by anti-10A levels, is going to be discussed a little bit more than I intended. So next slide. So weight-based dosing has this guidance that you're going to get patients on their more appropriate dose quicker. I really like this paper because it looks at what the percent within the target range should be. Now you can jump it up to 0.6 and you'll have more within the target range, but you look to that far right-hand column, you'll see you'll have more above it. So 0.5, as we see from this, is a safer way to dose. And if you're including the anti-10A levels, you'll find that right dosing with some follow-up measurements. Next slide. So here's the thing about weight-based dosing, and we've seen this at various centers, that you have to be careful with weight-based dosing. Picture the scenario where you have a 50-year-old who weighs 150 kilograms. Their creatinine clearance might be low normal. If you dose that patient on 75 a day per your weight-based guidance, you're going to be overdosing that because it really is the creatinine clearance that's guiding the excretion of the enoxaparin. Similarly, if you have some of these rail-thin patients you see who are 18 to 20, their creatinine clearance is going to be through the roof. They're going to have a much higher need than the 30 milligrams Q12 that the weight is guiding, and they might actually need 50 or 60 Q12 based on the anti-10A levels. So it's really the creatinine clearance. So my fellows from a couple of years ago, Yasar Hashim and Jessica Veach, wrote up papers. We looked at within our institution patients who required both high doses of enoxaparin, and then another paper, low doses of enoxaparin. And we compared them to those that require the typical dose. And what we found was that BMI and weight were not predictors of high dosing. Similarly, BMI were not predictors, and weight were not predictors of low dosing. It really is the creatinine clearance. So I think that weight provides a guidance for initial therapy. It's the biodistribution, the bioavailability, and the creatinine clearance. But I think you have to be careful because I think it's the anti-10A levels that are going to make sure you're not overdosing or underdosing. Next slide. Okay, dose adjustment by anti-10A levels. Groundbreaking. Oh my gosh, what are we doing here? So both agree, expert guidelines, large societies agree that you should be dosing by anti-10A levels. I would say that there are various papers that show benefit and there are various papers that show no benefit. Importantly, there's never been a paper that shows that patients have worse outcomes, higher bleeding rates, or any complications if you dose by anti-10A levels. So it's not going to hurt you, and it possibly is going to help you. I would also say that when I get pushback, because amazingly enough, I get calls from hospitals that have a complication. They want to talk about how to redo their trauma dosing, or I get calls from pharmacists who want to learn how to do this. You have a large percentage of patients who are admitted for a couple of days, and they never are in the hospital in time for an anti-10A level. So those patients are already out the door. If you're dosing them at 40 Q12, which they probably need for most patients, then you're already giving them the right dose. For the patients that have a long admission, you might only need one anti-10A level. You start them on 40 Q12, you find that peak or trough, you find this within range that you really, for most of their hospitals say will probably not need an anti-10A level. Next slide. So why is this? So as mentioned, there's a number of papers that have been shown to have a benefit. This was Ara Ko. She spent a year with me in research. She's at Stanford now. And we looked at, it was a pre-post comparison. So we looked at our historical controls, those trauma patients that we had on 30 Q12, and then we looked at this new program, and it was a massive effort because we had to do this with pharmacy, a pharmacy intern, and Russell Mason, and we had to go and write these adjustments. At the time, it was a little more challenging. We dosed it by anti-10A levels, and we prefer troughs. Next slide. What we found is 84% of the patients required more than 30 Q12. Nobody in this cohort required less than 30. And most of the patients, the median was 40 Q12. Next slide. And what we found was the mean start time for the patients were similar, about 2.5 days, 2.6 days. The median start time was about a day. Next slide. And the blood utilization, both median, there was no difference. And then next slide. And next one, VTE rates were better with this anti-10A levels. So this meant, go ahead and go to the next slide. This meant that our hospital was actually using this dose-based therapy. I think we were one of the earlier ones. I think there was pushback. I know Miami put out several papers that showed they didn't have a difference. So some of the items, you really have to be aggressive. You have to do this with a multidisciplinary approach. It takes sort of a system. So we wrote up this paper, and I think it went under the radar because we were looking at the system-based changes we used to get an anti-10A level as part of our trauma system. So this paper was important. It was Navpreet Dhillon. She spent a couple of years with me in research, and she's one of our scholars. She's at Shock Trauma now. And we did this pre-post comparison. So we used those same historical controls, and we now looked at patients where we were starting most trauma patients on 40 Q12, and we were adjusting by anti-10A levels. And we had similar findings that start time was similar. There was no increase in bleeding with 40 Q12, but we saw something that was really very impressive. VTE rate was lower when we started on 40 compared with 30. Adjusted by anti-10A levels, but we saw a decrease in PE. So this is absolutely part of our algorithm that we start at 40, and we've had pretty good results on it. We've seen a reduction in pulmonary embolism. Next slide. So moving on from type and dosing, let's talk about time is ticking. So Western trauma sort of had some hand waving. It said started within 24 hours for most trauma patients. And then I think AAST-COT had this sort of novel idea that said immediate dosing. So I like this idea of going out to the field and starting it, maybe starting it in the emergency department. Next slide. So why do we say that? Well, there's been a number of papers that show early dosing is safe. Solid organ injury, spinal cord injury, TBI. In almost every instance, early dosing of VTE prophylaxis is considered safe. With TBI, we certainly made groundbreaking moves in starting with VT prophylaxis with TBI. That paper in the lower left-hand corner is a military paper for penetrating trauma. For penetrating trauma, after you have a stable head CT, you can start dosing early. So when you have pushback about these small distal bleeds that we can't start VTE prophylaxis, I bring up this paper. Look, we've seen in gunshot wounds to the head that early dosing is safe. Next slide. And so it gets to this idea that immediate dosing is appropriate. It's dosing in the emergency department. We haven't really studied it, but I absolutely think we should jump on this. And we can't do it for all patients. For most patients, I think we should give them a dose of 40 or weight-based therapy. And it's time to move forward, and we're going to see a reduction. Next slide. So I think this needs to be discussed more, that uninterrupted dosing is probably contributing to an increase in VTE. And these things like procedures, epidurals, anything can lead to a held dose. Both societies agree that you do not interrupt therapy for almost every instance. Next slide. And I can hear Dr. Geert sighing that we have to even discuss this, that I think everybody would be amazed at how many doses we miss, certainly in my trauma center, and it's something that I deal with constantly. Our trauma center VTE prophylaxis guidelines is based on elective therapies. So for elective therapy, the recommendation is to hold VTE prophylaxis before surgery. For trauma patients, it doesn't work because surgeries are canceled, it's delayed, there's multiple surgeries, there's unexpected surgeries. So what happens is the intern writes to hold it. I try to push back, and I've tried to change our guidelines at our hospital, but they ask me to provide evidence, and it's really very challenging to give continuous therapy. So I just get back to the methodology from 1996 that says the studied drug was generally not withheld in the event of a surgical procedure, except in exceptional circumstances. So thanks for that 1996 paper. It's still working on it today. I would remind everybody that if the hemoglobin goes from 10 to 9 and the patient is normotensive and not tachycardic and there's no risk for shock, you can certainly continue it. That's another area where I get, well, why was VTE prophylaxis held? Well, the hemoglobin dropped from 10 to 9. I mean, certainly if it's 10 to 6 and you're worried about, shock, I could see reasons to hold, but I think those are exceptional. Continue VTE prophylaxis through most surgeries. The societies agree. Next slide. So this paper from Marty Schreiber out of Oregon is one of the reasons I believe this. I actually believe there's a rebound effect, that if you start VTE prophylaxis and then you hold 2, 3, 4, 5 doses, you're going to have actually a higher rate of VTE than if you had never given it. Why do I believe this? Well, this is both trauma and general surgery patients. If you hold between 2 to 4 doses of VTE prophylaxis, you're going to have 8.5 times increase in VTE. If you bump it up to 5 to 8, it's 10 times. 9 to 17, 14.7 times. So I think there's something going on the coagulation factor levels, that there's an upregulation that leads to a higher VTE rate when doses are held. And it's an area we need to emphasize. It's an area that we have to give it continuously. There's very few reasons to hold VTE prophylaxis once it's started. Next slide. So, and I think this is where the guidelines differ a bit, and I think I'd like to discuss that. So the one thing I would say is that we need more research in VTE prophylaxis after TBI. The neurosurgeons have this real concern about increasing bleeds, and we need to increasingly show that it's safe, that we can give VTE prophylaxis. So Western trauma had this idea that after a stable head CT, which showed no progression in bleed, it was okay to give VTE prophylaxis within 24 hours. It was safe. In difference, the COTAAC decided to go with the modified Bird-Norwood. So let's talk about that. Next slide. So this disagreement is based really on the modified Bird-Norwood says for those patients who've had a cranie or ICP monitor replaced, you go to the right, and that circle there shows that VTE prophylaxis maybe shouldn't be given, that maybe serial duplexes should be considered, maybe place a filter, but these are high-risk TBI patients. I think there's a number of changes since 2014. The risk of VTE after TBI has been better understood, the benefit of continuous early uninterrupted doses. So I think we can do better than the Bird-Norwood. And why do I say that? Next slide. Well, one is this Jack's paper from 2016. It's multi-institutional, propensity matching. There's a lower DVT&P rate in these severe TBI patients with early dosing, and there was no difference in delayed intervention. And if you look at that first graph, it looks like they're more comfortable with unfractionated heparin. They give it earlier. There's a higher peak there, and then enoxaparin, but they give the unfractionated heparin and the enoxaparin between about 2 and 4 days. And again, these are about a fourth of these patients had cranies, about a third of them had ICP monitors. And what they showed was an early, with a lower VTE rate with early treatment, and delayed intervention didn't really change. There was no significant difference if you gave early or late. The one thing I would say is bleeds do occur after TBI. Progression occurs, but they occur mostly before you start the prophylaxis, and they also occur after prophylaxis is started, but the rate of progression of bleed is about the same whether you give prophylaxis or not. Next paper. Next slide, please. Thanks. This is World Journal of Surgery, 2019. Very similar findings, early, intermediate, or late dosing, and with early dosing, there was a lower rate of VTE, and there was no difference in progression of bleeds if you gave early, intermediate, or late therapy. So I would think that even with severe TBI, you can give VTE prophylaxis. I do believe in occasionally doing duplexes, especially in the ICU. The patients have a lower PE rate, but I think that doing VT prophylaxis for severe TBI after a stable head CT is a reasonable choice. And I think the guidelines do differ on this, so it's an area that we might need more research. Next slide. So I think this will be the last paper I talk about. This is not pre-Dylan, and this is very interesting. So it really collects not VTE rates, but it collects the data on how we're doing. So this is a pretty good trauma center. We're very proactive with VT prophylaxis. We have written guidelines. This is a subset of patients. These are patients who all reached goal anti-10A levels. This are the patients who we dosed and we got to the target. So among this population, the Enoxaparin dose for TBI patients at our center, the median was 7.5 days. That's awful. The median for non-TBI patients was 1.5 days. And one of the reasons for that long delay is that heparin TBI is extraordinarily common for TBI patients. About half of our TBI patients are transitioned to heparin with heparin sub-Q instead of enoxaparin. Why is that? People feel more comfortable with heparin sub-Q still today in our hospital. Even 11% of the patients who had non-TBI got heparin sub-Q. Why is that? Well, there's certainly comfort among the orthopods that heparin sub-Q is safer, that it'll be given through surgery. I also think a small minority of these patients had low creatinine clearance, and so heparin was given. But that's a pretty miserable finding. Goal anti-10A levels. So I want you to consider this, that this is probably true for your hospital. You have a TBI patient. They're going to reach their goal anti-10A level. They're going to reach the appropriate prophylactic dosing if they have TBI after 11 days. We're not doing very good with TBI patients. It takes 5 days, a median of 5 days to reach it for the non-TBI patients. Still not very good. I would also say that the median enoxaparin dose for TBI patients is 40. This is what they need. So we need to get to this point where we feel comfortable giving 40 Q12 to TBI patients. Next slide. So there's a bunch of other stuff that I don't have time to talk about, but I'm just going to at least mention. VT prophylaxis with epidurals, it's completely changed. If you go back 20 years, epidurals were associated with a lower VTE rate. I think that related to Dr. Gertz's papers that we were more comfortable giving VT prophylaxis with epidurals. There was a black box warning by the FDA about using enoxaparin. That black box warning actually shows, if you go and read it, that the dosing we're using is appropriate. It just gave guidance about how to dose that. My hospital took that as marching orders not to give VT prophylaxis with an epidural. So we have published and others have published that the VTE rate is higher with epidurals, and we've actually showed there's no difference in complication rates, but it is really a challenge. NOACs are probably the future. I think both guidelines would like to use NOACs, but we don't have the evidence to indicate it from my reading of the guidelines and the literature, and that NOACs, some show better, some show equivalency, and some show worse with prophylaxis, so we need more data there. Discharge dosing. So we've heard this. The data we're presenting is really for in-hospital dosing, that discharging patients on higher enoxaparin level doses is probably unsafe. You don't monitor anti-10A levels, so we backed off on that. We'll do 30 Q12 or 40 once a day, certainly in rehab. We're more likely to use the Enoxaparin or Rivaroxaban. Aspirin has been shown in the hospital not to contribute to a lower VTE rate. But outside the hospital, it might be. Maybe patients are more mobile. Maybe it's the way to go. But in any case, that's the final, next slide, that's the final look at the guidelines. The summary is, we should be doing this. Initiate VT prophylaxis early. Make it immediately, specify anti-10A levels, continue at any time after discharge. Thanks so much.
Fantastic talk. Any questions for Dr. Ley? Dr. Beaumont?
Hi, nice talk. Thanks. Really enjoyed it. Regarding the comments about spinal fixation, quote unquote, being the compelling factor for withholding VTE profile, I think I'm the neurosurgeon with me, and it's interesting because we don't see cranial surgery there. Number one. Two, one of the things that we've done over the years is tried to point out to colleagues that actually we can give VTE to our patients before they leave. there's no risk associated with that, and we've done it on a high initiative, you know. So, does that also include intracranial surgery? Probably yes, is the question.
Yes. So just to your first point, there is now excellent literature about elective spinal cord cases where department chairs are saying, okay, we're going to decree this, and we're going to give preoperative spinal cord dosing. And VT rate decreases, there's not a change in intervention afterwards.
And with that data or in your institution, there quick buy-in with the faculty? Because the issue that I have is, you know, again, I'm the one neurosurgeon here, but so many faculty, particularly.
No, there isn't buy-in. There really is not. It's almost like going to Vegas because, you know, you're always going to win if you don't give prophylaxis, right? You're winning, and then down the road the patient gets a DVT. Well, I don't see that. It's not in my area. So it really takes conferences like this, it takes the literature, and then it takes a leader within the institution to decree this. So, yeah, we're getting there. I would say with cranial, it's the same thing. Yeah.
Sorry, then one other question with
I don't want to encompass everything. It's most epidurals, yeah, that you can dose, yeah.
One of our online participants. In presentation, the approach commonly used for starting early logic VTE prophylaxis in TBI requiring craniotomy.
So if the patient's in the trauma ICU, we can start it. We do have the residents, the second year on service will say start in 72 hours, and because they're in the trauma ICU, we'll start it after a stable head CT within 24 hours. But actually it's interesting, the neuro ICU is changing. The neurocritical care doctors are on board with this, but you know, I understand if you're the neurosurgeon, you've operated on this patient, if the patient's in your unit, then we're going to, you know, just do that. So it's a work in progress. I don't have a decree that will make it work for everybody, but the more that we have on this, like the one that Dr. Dillon wrote, the more we're going to see that we're doing a miserable job with these neuro patients, and we need to improve.
Yeah. Common problem that we face is post-craniectomy patients with
Yeah, especially if they have, you know, the ICP monitor in, or they have a drain in, and again, it's ICU specific. I wish there was a decree I could say that would work magically. I know when I'm on service, I will decide what's safe, and it'll be based on the literature. I've never had somebody want to quote literature with me, but that penetrating brain trauma shows it's safe. But sometimes they'll say, you know, within 7 days, and I'll say, okay, we'll wait for 48 hours. But most of the time, if they're in my ICU, I'll just say, well, go ahead and start it and have somebody call me, you know, at a higher level if they want to discuss why. And then in our trauma fix, we also discuss it. And they're getting more proactive. I mean, imagine starting in 86 and being at this point. I imagine 10 years from now, we have, from San Diego, you folks, I think that it's going to happen, that people are realizing that these complications are significant enough that we need to do a better job.
To add to that, too, because it's another area, drains. Our institution, when I was at WashU, what we did is we had a departmental officer basically decreed drain was a contraindication starting VT prophylaxis.
Yeah.
And it worked.
It's really at the intern and second level. It's the people writing the notes and making the decisions, and then somebody will cancel my order. I'll say, yeah, just go ahead and change that back. And, you know, if they want to talk about it, I love discussing it.
I think this gets at the fact that we have this gap between what the data shows and how we implement, and a lot of it's based in bias, right? Just personal bias, specialty bias. You know, and maybe we'll get at this a little bit later in the conference, but I would like to think about strategies where we can overcome this, either whether it's getting all the neurosurgical societies together to say this is okay to do, you know, because you're right, it's sort of variable. If they end up in the neuro ICU, it's going to be different practice than if they end up in the trauma ICU, and that's really not good for patients.
Correct, Dr. Folger. Yeah. Sure, thank you.
Let's make a comment about what we're talking about here. There are so many thoughtful people who express their views on this in an individual organization. There are just too many people able to express their views. The way it works for us is we get people in a room, we say, this is what we're going to do. If you disagree, let me know. If not, we're going to implement it. And the delivery of this is based on post-admission and post-op order sets, where the order sets are standard. They give a dose of prophylaxis based on the patient's weight, and you have to have a justification put in the order set to overcome that. And there are some situations where you would want to avoid giving an anticoagulant to a patient, but there are not many. And so I think the default has to be the patient gets prophylaxis based on the evidence that we have. And we don't have these kind of discussions at our place amongst everybody who wants to do their own thing. It doesn't happen. Everybody is rowing in the same direction.
Yeah, over drinks last night, we decided to call you the godfather of VTE prophylaxis. So thank you for your thoughts. I don't imagine anybody's ever disagreed with your thoughts there in Canada. Yeah. Dr. Joseph, yeah.
Eric, you kind of mentioned in one slide the missed doses, and with the shortage of resource in hospitals, this is becoming more. One nurse is now to like 9 patients or 10. Those doses to be delivered on time when they're supposed to be delivered is still not even like entertaining. I mean, what we give, when we give it, how we give it, but the other side is delivery, and that is another area where I think there needs to be more work and question of the missed doses and what do we do if the nurse is 1 to 9 patients and needs to give, and has got a little emergency and they can't get to the patient.
Or the patients in CT or the patients in the OR, and you wonder, if you delay it by 3 or 4 hours, I get your point, and Dr. Joseph, it's really, really profound.
Great talk and good comments, and we'll look forward to hearing. Obviously, there's a lot of controversy related to the neurosurgical field, so we'll look forward to hearing the neurosurgeon's perspective this afternoon.